Okay, hello, everyone. Thank you for joining in this session. Now it's time to start this session. This session is about hepatitis B novel detection method for HBV markers, and we have three splendid lecturers here. Dr. Atsamasa Komori and Dr. Yasuhito Tanaka and Dr. Henry Chan from Hong Kong. Okay, please stay in this room, and we welcome active discussions and comments. Okay, first I move on to the first session, first talk by Dr. Atsumasa Komori. He is from a Department Treatment for Institute Disease of Nagasaki Medical Center. Title of his talk is Rethinking the Disease Status of Chronic Hepatitis B, the Role of Novel Detection Method for HBV Markers. Okay, please start your session.
Thank you, Professor Sakamoto, and it's a great honor to be here as the presenter of the Nobel detection method of HB markers. I am from Nagasaki and general hepatologist. That's why I'm going to present the kind of general hepatologist view of Nobel detection of HB markers before the two world experts will present their very new findings. I don't have any conflict of interest for this presentation. So let's start from the kind of perspectives in the personalized evaluation of HBV infection regarding clinical decision making. So we should have the kind of the aims for the decision making to indicate the treatment, to predict treatment response, or predict the hepatocellular carcinoma occurrence, or even prediction deactivation. So mainly those parameters, we should think about the aid of the viral load from the highly residual to minimal residual. So for patients with chronic hepatitis, we should prescribe NUCs, but on the contrary, for the inactive carriers, we may find a spontaneous clearance. But anyhow, again, we should tackle with the viral load from high residual to minimal. So in that sense, we should have, it's better for us to have the kind of surrogates for viral load life cycle in hepatocyte. The surrogates are mainly the serum-based biomarkers HBV, including HBC antigen, E antigen, or kind of that, and the HBC core related antigen, which I'm going to present in the next part. Again, as for the treatment, we should have multiple steps of endpoint HBV cure. Even after NUCs implementation, from the incomplete cure to partial cure through to complete cure. In the course of the treatment after NUCs, for example, 1 year or 5 years or something like that, and some guys are the privileged to be off of the NUCs. But the recent paper indicate the kind of distribution of the intrahepatic viral replication or transcription are even heterogous. And I'm very astonished to see the distribution of S antigen and core antigen are totally distinct. In the course of the treatment, either E antigen positive or negative, after the treatment of NUCs, the core antigen positive hepatic cells, liver cells, may not be changed dramatically. But in case of, S antigen, But in case of co-antigen positive cells, after the treatment of the NUCs on the course of the drug treatment, the amount of the intrahepatic co-antigen decreased, so indicating serum HCV antigen or HBC related antigen probably as surrogates for treatment response. And further, if we have the highly sensitive assay for the detection of serum HBV, we should rethink about the definition of the cure. The definition could be updated and rethought if we have the highly sensitive assay. The recent paper, the co-author includes Professor Chen. The HBV is present in the CCC form or in the integrated form. If they put out to detect the CCC-derived transcription or integrated DNA-related transcription, the amount in which decline in the treatment of the NUCs are distinct between from CCC1 and from integrated site. So after the kind of introduction, I'm going to introduce the review for the recent sensitive method for the detection of the HBV serum markers. First, HBs antigen or HB core-related antigen by ITACT system. ITACT system should be discussed fully matter by Professor Tanaka, but from my understanding, ITACT system enables us to first detach antibody-bound antigen to the antigen and antibody separately after denaturation and inactivation, something like that. So that technique enables us to analyze precisely for the transcription activity of S antigen or HBCR antigen with regard to disease status, probably ignoring the host response to produce antibody. So this data are from the group, including Tanaka sensei. If we implement the higher sensitive ITACT system for detection of the core-related antigen or S antigen, even after the seroconversion evaluated by the classical method, even after the classical seroconversion, the S antigen positive guys remained significantly. And even the percentage or prevalence of the positive residual HB core antigen are more comparing to the S antigen positive patient. Of course, the level getting near the lower sensitive limit, but again, the newly highly sensitive technique should us to rethink about the state of minimal residual viral load. This paper was also from Tanaka, Professor Tanaka. Professor Tanaka's group compared or analyzed before and after the conventional seroconversion. The parameter are ITACT HBCR antigen or ITACT S antigen, very sensitive one. So their analysis was focused to compare the chronic hepatitis patient and inactive carrier, and to evaluate which comes first for the cell clearance of S antigen or core-related antigen. So comparing to inactive carrier, which is first, which is the second, the pattern was different between CH and IC. And according to kind of the distinct the kinetics of the data, they may indicate that the HB coagulated antigen may matter more than S antigen for the progression of CHB. And Toranomon Hospital, Professor Hosaka recently published the prediction of hepatocellular carcinoma after nuke therapy using ITACT S antigen or coagulated antigen. Again, after the introduction of nuke, before 1 year, the decrease of the antigen was more in coagulated antigen than S antigen. And the level of the coagulated antigen, with the level of coagulated antigen, we can subdivide the patient risk for hepatocellular carcinoma occurrence. And they checked the transition from the high level of coagulated antigen even to high, even after treatment, or high to low, or something like the transition. The lowest risk was found in the from to low group, but even high to low group, the risk was decreased significantly. The second part, it was also established in Japan. All glycosylated middle protein is S antigen of genotype C. It is very special for genotype C detection. So Angata's group found out among L or middle or S antigen, they found the highly glycosylated residue in the M antigen compared to L antigen. So they established the monoclonal antibody against these highly glycosylated residue. So using those antibody, they check the kind of the inhibitory activity for the HBV replication. After adding anti-glycosylated PS2 anti-M antibody, replicated DNA level was decreased significantly comparable to the addition of HBIG. And the two papers have been already published from the Japanese group. The first one was the E antigen positive or E antigen negative patient who were treated with NUCs. Before and after NUC treatment, the DNA declined as long as the S antigen, co-antigen, something, but all glycosylated S antigen was also in decline significantly. And the last paper from the Shinshu group, they found out or evaluated association between the HCC, the group with HCC history or not. And finally, they found the risk was highest in the group with low S antigen, but with high glycosylated S antigen group. It was the associational study, but the multivariate analysis clearly found out DNA and clearly found out it was the risk for the hepatocellular carcinoma. So finally, in our center, tertiary care center, we have implemented those three markers into the clinic. So namely association between serum HBs antigen high quality, S antigen GI, or coagulated antigen, and the future occurrence of hepatocellular carcinoma among CHB patients treated with NUCs. The patients were enrolled from 1995 till 2021, and number 232 patients were the participants for the future further analysis. The serum S antigen and the coagulated antigen by ITACT and S antigen glycosylated are measured by Fujirebio Lemi-Pulse system. I'm going to show the clinical demography before NUCs. So firstly, the cumulative incidence hepatocellular carcinoma after NUCs are subdivided, classified by the pretreatment M-page B, the kind of the risk classification for that hepatocellular carcinoma in CHP patient. So totally, the risk of HCC was like 12% for 10 years. But after the stratification and page B, we have divided the three groups according to the M page. Then we analyze the pre-treatment S antigen, antigen GI, or correlated antigen, and the future occurrence of hepatocellular carcinoma. As you can see, probably we have the younger patient with a high viral load, but relatively low probable risk of hepatocellular carcinoma. That's why the higher amount of viral load may have the lower risk of the future hepatocellular carcinoma according to the pre-treatment level. But in terms of the 1 year decline, annual reduction viral markers, okay, we have the check the kind of cutoff. As in the Hosaka's paper, the decline less antigen or core-related antigen, or not so much, or even as antigen GI. But after dividing the patient into two groups, higher reduction or lower, okay, in case of S antigen, the higher reduction may limit the risk of the HCC, but in case of a GI and the correlated antigen, okay, in case of GI, the annual decline is around 6%, the cutoff, but the more decline may put the patient at the less risk of the future hepatocellular carcinoma. And again, it should be true in the decline of core-related antigen. And the association between 1 year changes in those serum marker and the occurrence of HCC. This line is the before and after. If the patient, the number are concentrated in this line, the no change of the viral markers before and after treatment. The red one were guys with HCC. As you can see, in case of correlated antigen, the more decline may have the less prevalence of hepatocellular carcinoma among those patients. So conclusion, implementation of novel detection methods for HBV markers into clinics may not only add a new aspect in disease status, but also revolutionize the strategy of monitoring CHP patient by updating the concept of functional cure. Thank you for your attention.
Thank you, Dr. Komori. He presented the high sensitivity assay of HB S antigen and correlated antigen by using the ITAC method, and also a highly glycosylated HBS antigen assay and its association with hepatocalcinogenesis. Okay, this paper is open to discussion. Is any comments from Dr. Tanaka?
So I'm Tanaka. Thank you very much for wonderful talk. So my question is HBS antigen GI.
Yes.
So did you check in correlation between GI and correlated antigen? So for example, during treatment patient, NUC treated patient.
Okay, we have the raw data, but I'm sorry not to be in the process of that kind of finding out the correlation.
Because your data show in very similar in changing of the correlated antigen GI, HBS antigen GI. Okay, thank you.
Bye-bye.
Okay, please.
Yeah, thank you. Very nice talk. I'm TC Zeng from Taiwan. Yeah, I noted that you just showed that the patient in your data, the patient with higher viral protein for example, the higher surface antigen level is associated with a lower HCC risk. Is that correct?
Correct.
Yeah. So actually, this is very similar in our finding in patients without antiviral treatment, but
Yeah.
it's only in E-positive patient. So I just wonder if you have a chance to split your population into the E-positive and E-negative to see if the correlation is only hold true in E-positive but not in E-negative.
Thank you very much. Not yet, but as you mentioned that the cohort may have the bias for the including the kind of high viral load with a less chance being of the treatment or something. But anyhow, those guys have been already treated by nukes. We should divide the kind of precisely or scrutinizing the kind of the population difference. Thank you for your comments.
Please.
Yeah, thank you. Very nice talk. I'm wondering, did you check the glycosylated small s?
Glycosylated small s. Okay. So sorry. This system has been already commercialized. We have not involved in the kind of the development of that antibody. So I have only checked the presence of the M antigen highly glycosylated one.
Okay. Is the glycosylated M protein in the form of the SVP subviral particle or in the free form of the protein?
So it is a matter of the kind of the clinic basic virologist. I don't have any kind of the precise answer for your. Probably the Professor Tanaka may have.
Thank you.
Thank you.
Okay, please.
So, so I'm Dian from Vietnam. So it's just not just your talk is impressive, but just think about the costs and the difficulty of doing those stuff, because I'm thinking about like accessibility and the feasibility to like you know like low resources country. So whether
Okay, you mean that the availability or accessibility or implementability of those guys, those
exactly
methods? Okay,
exactly.
We should be very serious about the kind of the potential for the implementation. But okay, ITAC system, Professor Tanaka, I'm going to present kind of the results. Very highly sensitive. But in case of the primary care, the higher sensitivity may come next. So that's why the appropriate the detection or the choose of the surrogate marker are necessary for the each distinct phase of HBV viral hepatitis. That's why our data are for the find out the association between risk and the kind of viral presence or serological markers. So that's why I'm so sorry for not giving you the kind of appropriate answer, but the appropriate the way of implementation or availability of those markers should be discussed seriously future. Thank you.
Thank you.
Thank you very much for the lecture. My name is Ayush. I'm from Mongolia. So I would like to know what kind of antigen did you use in your study? Because the origin of antigen might be different depending on the prevention of HBV genotypic distribution. Like if you're, I mean, if you use it like antigen extracted from the Japanese people, this test might be very good. This test had a very good sensitivity specificity for Japanese people population. If we use it directly copy and use in like other country, should we use the our country genotypic antigen?
Okay. I have the friends from the Central Asian country or other Asian country. I may know well the kind of distinct prevalence of the genotype. Again, the glycosylated antigen detection is the genotype C specific, so not translated into other genotypes. So probably those guys are very specialized for the detection method of that glycosylated protein may have the chance to detect the another guys for the detecting non-genotype C M antigen, but we are not sure. But anyhow, in the place of apostle, gathering all together in an Asian country, again, I agree with you. The kind of the usage or appropriate combination is very necessary for future. Thank you.
Yes, same as the question to the limitation with genotypes. Limit the clinical utility of the highly glycosylated assays. In contrast, the glycosylation site is as the middle HBs antigen, and this is dominant component of the viral particle. But for the S antigen, the empty particle is mainly composed of only a small antigen. That I think that HBsGI may reflect viral titers or treatment response. Is there any time course data of the S antigen GI?
Thank you.
No?
No.
Do you have in okay.
No.
Okay. Then okay, almost time's come. Please, thank you, Dr. Komori. Okay, next speech is by Professor Yasuhito Tanaka of Kumamoto University. His title of talk is Novel Biomarker for the Management of Chronic Hepatitis B. Dr. Tanaka, please.
Okay, thank you very much for introducing me. So I'm Yasuhito Tanaka, Kumamoto University. So I'm happy to talk about this novel biomarker for management for chronic hepatitis B. This is my disclosure here. So today's topic is firstly clinical useful correlated antigen. Sometimes some parties overlapping Dr. Komori talking about. Number second is high sensitive ITACT HBCRAG as well as high ITACT HBS antigen assay. So if we have time to strategy of preventing mother-to-child transmission, however, we have no time today, so move to new anti-HBV compound RNA destabilizer. This is new compound. So this one, we have several HBV serum marker HBV DNA by real-time PCR. Also, we detected recently quantification of HBs antigen, including empty particle as well as small s. So overlapped, we detected correlated antigen, including E antigen, empty particle, then particle. These particles interestingly produced from cccDNA in liver tissue. So HBCRAG assay detected 3 independent in mixture in particle. So for example, HB core protein core antigen, E antigen, P22. CRAG is the nature mixture consisting of 3 independent in particle. This P22 precore or P phosphorylated core protein including empty particle. So recently, we have in retrospectives large cohort study including more than 1,000 patients, including genotype A, B, C, D, E, F. So you can see several genotypes are available for HBCRAG, good correlation between HBV DNA and HBCRAG by HBV genotypes. So interestingly, correlation HBV DNA and HBCRAG, you can see HBV DNA more than 2000 IU per ml inconsistent to HBCRAG 3.6, 20,000 IU per ml DNA according to in HBCR is 4.5, also 200,000, 5.3 is good correlation between HBV DNA and CRAG. So maybe in developed country or limited country, HBCRAG might be alternative marker for HBV DNA. Also, CRAG is good correlation cccDNA better than HBV RNA, also HBV S antigen, even though E antigen status. So interestingly, CRAG better correlate with cccDNA, compare S antigen, HBV RNA, regardless different inflammatory, even though the higher 2D2, or serum HBV DNA level more than 8 log IU per ml. So natural cause HBV infection. So E antigen positive in also chronic hepatitis C, hepatitis B, also anti-HBe positive, E antigen negative chronic hepatitis B. So HBCR level during E positive, also HB negative phase. Even high sensitive assay is available for E antigen negative phase. So this paper is published in Dr. Kao's group. So high level of HBV correlated antigen associated with increased risk HCC in patients with intermediate viral load. This is very important paper. So patient with intermediate viral load between 2,000 to less than 20,000 IU per ml intermediate, high level of HBCRAG level more than 10 kilo unit per ml, 4 log unit per ml, had high risk HCC. This is different, significant from that patient with high viral load more than 2,000 IU per ml. So indicating intermediate viral load group, so combination is very important. Correlated antigen combination is very important. Subgroup of E antigen negative patient with LT normal less than 40 unit per ml. Incidence HCC was higher in patients with high viral load, more than 20,000 IU per ml, and those with intermediate viral load again, and high level of CRAG. You can see is very similar risk of HCC development. So summary first, CRAG is correlated with the HBV DNA in serum as well cccDNA in liver tissue. In subgroup, E antigen negative patient with normal LT, CRAG as well as HBV DNA would be surrogate marker for anti-HBV treatment indication. So Dr. Komori also mentioned several papers describe the prediction of HCC development by HBCRAG assay. So this paper is Dr. Hosaka mentioned in described paper incidence of HCC development according to serial HBV CRAG level during nuke therapy. So this is overlapping. This is in starting with an entecavir patient. Patient with persistent high on treatment HBCRAG, for example, more than 4 log unit per ml, has higher risk likely to develop HCC despite sustained viral suppressing by a long-term nuke therapy. So in basic research also show 9 HAV genes, including cancer-related signal, upregulated in HBCR positive in liver tissue. So for example, pro-apoptotic oxidative stress Wnt signal is upregulated by HBCRAG positive liver tissue. Also, HBV transcription-related factor is associated with HBCRAG positive patient. So HBCR positivity degree hepatic fibrosis independently predict HCC development among patients receiving nuke therapy. So summary second, persistent high HBCRAG level have been significantly associated with the risk of progression or recurrence of hepatocellular carcinoma. So move to strategy for cessation of nuke. So criteria for stopping antiviral therapy, several guidelines described firstly HBV DNA undetectable, e antigen cell conversion, HBCRAG reduction or S antigen reduction. So previous our data show comparison of serial HBCRAG level between relapse and non-relapse after cessation of NUC therapy. 22 responded to stop NUC therapy. So you can see non-relapse patient is lower in HBCRAG during NUC therapy until end of treatment. So we're checking in mean HBCRAG level at the end of treat of NUC therapy. You can see HBCR level of non-relapser was significantly lower than in relapsers. So Japanese guideline, JSH guideline is scoring relapse risk after cessation of NUC-based HBS antigen and HBCRAG. So we reported cutoff line determined by ROC curve. HBS antigen is less than 80 is low risk, scoring is 0. Correlated antigen also less than 3 log unit per ml in low risk mean score 0. For example, S antigen is more than 800 is high risk, scoring 2 like this. Total score is 0 mean low risk. 1 to 2 is mid risk, 3 for 2 in high risk group. So scoring of HBCRAG and HBS antigen is more useful to prediction non-relapse after NUC therapy. Only 10% in relapse in low risk group. HBCRAG less than 3 and HBS antigen is less than 80. So recently collaborative retrospective will be large cohort study probability of HBS antigen loss after NUC therapy withdrawal in dependent HBV genotypes on viral antigen level. So this paper concluded non-Asian and genotype A associated with HBS loss after cessation of NUC therapy. Also, we combine HBS antigen correlated antigen to predict HBS antigen loss. Most important factor HBS less than 10 at the end of treatment. You can see 40% is HBS antigen clearance after cessation of NUC therapy. Also, intermediate groups. Undetectable HBCRAG less than 2 was associated with significant higher probability of HBS loss among patients in HBS of 10 to 100 IU per ml. Patients with both in HBS antigen more than 100 undetectable HBCRAG had very low chance of HBS antigen loss after cessation of NUC therapy. Oh, this is Memorial 9th Japan, Taiwan, Korea HBV meeting in last year. So move to high sensitive ITACT HBCRAG assay. So today we talk about two-part development in fully automated highly sensitivity HBCRAG reagent. Characteristics of ITACT HBCRAG, result of basic performance evaluation, utility in diagnosis of HBV reactivation. So you can see ITACT HBCRAG assay measurement in practice. So you can see HBV particle and immunocomplex and destroyed by the pretreatment in process, and the antibody, HBC antibody inactivate, core-related antigen are linearized and detected by CLEIA. So this is conventional previous HBCRAG. Also, this is ITACT HBCRAG. You can see we compare between two assays. So you can see ITACT HBCRAG is automatically on board. Only 33 minutes to detect in HBCRAG. Interestingly, in cutoff line, sensitivity is 10 times higher in ITACT HBCRAG compared to conventional HBCRAG. So also recently published ITACT HBS antigen in cutoff line 0.0005 IU per ml, 100-fold higher than conventional HBS antigen assay. So result of basic performance evaluation. So this paper is published in 2021. Basic performance evaluation ITACT HBCRAG. Main component HBCRAG detected in the early phase of HBV reactivation. So the count concentration below 0.5 kilonewton per ml low concentration was quite distinguished from the negative control. This is negative control in ITACT HBCRAG. So conventional HBCRAG conventional assay is very similar in negative control. So reliability cutoff line CB 3% were established at 1.9 log unit per ml and 2.8 log unit per ml ITACT HBCRAG and G conventional HBCRAG respectively, indicating 10 times higher ITACT HBCRAG. So monitoring E antigen negative phase. So comparison between the rate HBCRAG detection by ITACT HBCRAG versus in conventional CRAG in sampling from NUC-treated patient, especially E antigen negative patient. So HBCRAG undetectable by conventional HBCRAG in the cell 25% patient. On the other hand, HBCRAG was undetectable by ITACT HBCRAG in only 2.5%, suggesting the assay was more sensitive. So also Dr. Komori is mentioned in recently collaboration. Dr. Yuen's group examined detection rate of HBs antigen and or correlated antigen after HBs cell clearance 0.05 using high-sensitive ITACT assay. Cutoff line is here, ITACT HBCRAG 2.1, ITACT HBs antigen is 100 different in conventional HBs antigen. So again, profiling 3 serological marker at different time point over 10 years in occult HBV infection with HBs cell clearance. None of nuc therapy in this group. So very surprising data ITACT assay detected in low titration HBs antigen and or HBCRAG in more than 17% patient even at 10 years after cell conversion, indicating in several patients in occult HBV infection. So move to utility in the diagnosis HBV reactivation. So clinical question, is ITACT HBCRAG useful for monitoring HBV reactivation? So comparison varies high sensitive assay from serial sample obtained from 13 patients. This point is HBV detectable, first detectable point. Surprisingly, in 12 of 13 HBV reactive patients were correlated positive by ITACT HBCRAG before or at HBV positive patient. Also compare high-sensitive HBs antigen. 12 patients were CRAG positive ITACT HBCR before HBs positive by high-sensitive ITACT clear assay. So regarding patient HBV reactivate, ITACT HBCRAG clearly detectable earlier than high-sensitive HBs antigen. So what kind of in particular can we detect? Because in ITACT HBCRAG detected before HBV DNA positive become positive. So OptiPrep density graduating ultrasensitive graduation analysis of HBV pre-HBV DNA detection in patient with HBV reactivate. So you can see we detected empty particle not including HBV DNA. So in the early phase, HBCRAG dominantly detects empty particles produced mainly from cccDNA. So report 3 in HBV reactivation patient, comparison of detect rate ITACT HBCRAG HBV DNA quantification. So we include 14 for patient, HBV reactivated patient. So we divided two groups, HBV DNA more than 1.3 quantitative. Also HBV DNA is less than 1.3, is a very low titration signal positive patient. So usually we detected quantification HBV DNA, we started nuke therapy. So you can see comparison positivity ITACT HBCRAG and HBs antigen. So more than 96.3% is positive ITACT HBCRAG, around 89% is positive ITACT HBs antigen. So high detection rate at ITACT HBCRAG and ITACT HBs antigen in HBV DNA quantitative patient, potentially as indicating on nuke therapy in the introduction. So summary for monitoring E antigen negative chronic hepatitis B and HBV reactivation. For HBV reactivation, ITACT HBCRAG was detectable earlier and longer than HBV DNA and high-sensitive HBs antigen, potentially as indicator of nuke treat introduction. So finally, I talk about in simply new in compound. So skip this one. So listen, this is key slide effectively we new compound, subcompound, add on treat and entecavir. You can see by the combination treatment, sub and compound and entecavir, HBV DNA and HBs antigen was reduced immediately, but not HBs antigen by entecavir alone. The combination therapy is in better than entecavir monotherapy. So studying RNA destabilized brick assay system. Studying RNA destabilization by brick assay, subcompound reduce HBV RNA only, not GAP-DH albumin. Subcompound destabilize HBV RNA, not GAP-DH albumin. So what is sub-targeting? Recently, several papers described in PAPD5-7 in RNA binding protein non-canonical in polymerase. So subcompound also in binding PAPD5 stabilized by SAG treatment. SAG binding to PAPD5, not in PAPD7. Also, subcompound reduce HBs antigen, but SAG action attenuated by SI-PAPD5. So subcompound exerts the anti-HBV effect via PAPD5. So summary is MOA subcompound in HBV RNA destabilizer subcompound targeting RNA binding protein PAPD5, for example, stable RNA, one subcompound in administration, HBV RNA destabilization, reducing HBs antigen, HBCRAG. So right now we preclinical trial 2 weeks or 13 weeks repeated oral toxicity of subcompound in monkey right now. Subcompound show no overt toxicity in monkey. No air of subcompound is 1000 milligram per kilogram per day. So autopsy result in no change of all organs such as liver, kidney, nerve and observed. So summary conclusion, subcompound decrease HBV DNA HBs in both in hepatitis cell and PXB cell, show anti-HBV activity against multiple genotypes A, C, D. Destabilize HBV RNA, reduce HBV markers, in planning to clinical trial in next year. Okay, take message conclusion, high sensitive correlated could be useful for clinical practice, E antigen negative patient and anti-HBV therapy to prevent hepatitis due to HBV reactivation. Antiviral prophylaxis is recommended for E antigen positive patients at baseline, whereas regulatory monitoring HBV DNA or high-sensitive HBCRH guided preemptive anti-therapy would be useful for patients with resolved HBV infection. Novel anti-HBV drugs such as RNA inhibitors on development toward functional cure. So this is the final slide I hold in JSH 16 JSH meeting in Kumamoto. So we try to the first JSH Tassel Castle Joint Symposium during JSH annual meeting in June 13 and 14 in Hell Kumamoto. We welcome to Kumamoto. Norwich, thank you very much for your attention. Thank you.
Okay, thank you for your presentation. This paper is open to discussion. Okay, please.
I have small questions. So for the correlated antigen test, we pick up 3 components. So in your tests, it's like whether in any case that this test may pick up differently toward the 3 components. For example, it pick up this more than compared to others. And also when in the patient that receiving, like, for example, NUC is like, it will change that nature, like it may pick up the other components more too. So yeah.
So I'm not sure. Pick up your question, please.
I mean, we have 3 components when we do the test for. So whether your test may pick up this more compared to other, and when you treat the patient with the drug, it may change that thing as well. So it may pick up the other components.
We try to co-protein only. HBCAG is very important factor. So, however, detection limit of not so good for HBCAG only. Then we decided to combine HBCRAG, including several particles, including E antigen, empty particle, CAG. Right now, we developed, as you mentioned, developed independent in particle assay. Thank you.
And the next thing, like whether the way it pick up the components may be like a difference between like treatment regimen, that maybe we should use it one for this treatment, but the other one we should use one for the other treatment.
That's right. Recently, we tried a clinical trial in antisense oligo or siRNA. What happens CRAG? We don't know right now. So I agree. We should examine 3 independent in particular. Thank you.
Thank you.
Good question. Thank you.
Okay, please.
Yeah, thank you, Professor Tanaka. Very nice, comprehensive talk. So a quick question. I noticed you have a slide showing that there is a discrepant correlation between the correlated antigen and cccDNA and HBV DNA and cccDNA. You suggest that correlated antigen is a better surrogate marker for cccDNA. Is that correct?
Yeah, I think so. HBV RNA is also a good marker. However, sensitivity program is HBV RNA assay. So we develop high sensitive HBCRAG right now. Then I believe HBCRAG is much better to correlate it with cccDNA.
Yeah, so but my question is, both the DNA, RNA, and correlated, they are coming from cccDNA. I suppose their prediction performance should be very similar.
We have to separate E antigen positive phase and E antigen negative phase. Quite different between E antigen positive phase and negative phase. So CRAG is very good candidate E antigen negative phase especially. So I agree. E antigen positive and negative should be separate.
Yeah. Okay. Thank you.
Dr. Komori.
So Komori, Nagasaki Medical Center. I'd like to hear from you about the perspective of the probability of the cessation of nukes in terms of the age of the antisense oligo drugs or something like that. S antigen and correlated antigen are very useful, the candidate for the determination who could have the cessation. So in that sense, those guys could use in the near future in terms of the usage of the antisense oligonucleotide drug or something like that. Whether which patient are the really candidates of the add-on or not.
Yeah. So right now we have several clinical trials right now. Company focusing in functional cure HBs antigen less than 0.05. However, very few chance, only 10% or 20% is achieved functional cure.
Right.
So I think in clinical practice, we focusing partial responder. If patient partial responder, for example, HBs antigen less than 10, or HBs antigen is less than 100 and correlated antigen less than 2. So because after sensation of such patient, 40% achieved HBs antigen loss after sensation of nuke therapy. So I think in clinical practice, clinical trial and clinical practice is quite different in focusing on functional cure.
Thank you.
Yeah, very nice talk. I have two questions. The first one for the S-loss patients, those who relapsed versus non-relapsed. Did you also check the antibody level, anti-HBs level, and also the maybe T cell response? Does that have any effects to the relapse?
Yeah, very good question. So we checking antibody. Once patient become positive for HBs antibody, continue to HBs antigen loss, not undetectable. However, we don't know in T cell response. We try to PBMC trial for using in T cell response after sensation of nuke. So I have no idea right now. Thank you. Good question.
Okay, another question. For the patients who has the HBsAg low versus HBsAg higher, did you also do the virus sequence analysis? Do you see any differences regarding the viral sequence?
Yeah, sometimes some discrepant patient, HBs antigen high and HBcRAg low. So opposite patient also S antigen is low, correlated high. I think problem is HBs antigen low and HBcRAg high patient is high in future develop HCC. Already several papers describe CRAG is associated with HCC development because HBs antigen also detected small HBs antigen is not an important factor for HCC development.
Okay, thank you.
Dr. Chan.
Hi, congratulations, Tetsuo, for your very nice work on ITech HBcRAG. I think you've contributed much to the scientific community here. I want to ask, now we have a very, very sensitive test that is positive even among patients with S loss. And one of the clear possible clinical usage is to predict reactivation, say on chemotherapy or on immunosuppressive therapy. So have you identified certain cutoff of the HBcRAg using ITech technology that can predict who will relapse and who will not?
Yeah, very important. So because I have some data, if patient HBcRAg less than 2.1, it's very few chance to reactivate even though treatment. So cutoff line is 2.1 is very important for prediction in HBV reactivation.
So we need the ITech then, because the conventional one cannot take measure down to 2.1.
That's right. Thank you. Thank you.
And Dr. Tanaka, at what time point do you decide to start the nuke therapy at the reactivation? Do you decide nuke therapy when its co-antigen level is more than 2.1?
Yeah, because we show in HBcRAg detected before HBV DNA become positive. So some patient we detected empty particle, not necessary to treat such patient. So my strategy is HBcRAg, if increase HBcRAg 2 point, then we decided to treat nuke therapy. Some patient disappear in HBcRAg. Such patient no needed to nuke therapy during treatment.
Okay. Okay. Time's come. Thank you very much, Dr. Tanaka.
Thank you.
Okay, I introduce the last speaker, Ali Chen. He's now in the Department of Union Hospital. He was the professor of the Chinese University of Hong Kong. You don't need to do the introduction in detail because he is a globally renowned professor of the hepatology. Today's his title is HBV RNA. Is it ready for clinical use? Please.
Thank you very much for the kind introduction. It's my pleasure to be in Kyoto after, I think, 17 years since a parcel in Kyoto. So it's a very nice city. I hope you all enjoyed it. So today I'm going to talk on HBV RNA. I'm so glad that we have not overlapped too much on our topics. So these are my disclosures. HBV RNA is actually a very heterogeneous population of RNAs. So there are many forms. In general, we have full-length form and we have truncated forms. And these are very important physiologically for the virus because it is important in the nucleocapsid assembly. And what we are measuring right now is primarily the full-length form in encapsulated forms, and there are few very good studies to prove that. So this is just a schematic diagram to show you how complicated it can be when we talk about HBV RNA. But in fact, what we are measuring is the full-length form reflecting the amount of pregenomic RNA that is reflecting a viral replication. There's still a lot of other truncated form in many other sense, and these can originate from cccDNA and also integrated HBV DNA. And normally they're very poor association with HBV DNA, HBeAg, ALT, or age, as shown by many different studies. So in my talk, I'm going to focus on the role of pregenomic RNA in clinical practice. Initially, people are excited about RNA because they think it can correlate with cccDNA. But with subsequent studies, it showed that it reflects actually more on the transcriptional activity of cccDNA instead of the total amount of cccDNA itself. So this is a very recent publication on a comprehensive analysis of HBV RNA in 122 untreated patients with liver biopsy. And the investigators found that the serum RNA is correlated with the intrahepatic RNA and also the intrahepatic RNA over cccDNA ratio. So this is the overall comparison, and these are they only look at the quantifiable range. So take away all the undetectable and they exaggerate the difference between the RNA negative, the serum RNA negative, and the serum RNA positive patients. Now, the reason why I'm talking about whether it's regular clinical use is because there are assays to measure it right now. In the past, most of the assays are homemade, but now we started to have commercial assays. Well, the first assay coming out is the Abbott RNA system, and it amplifies both the HPX and the core region. The first version was not too sensitive. The sensitivity was 150 copies per mil, but version 2 is actually very sensitive, down to 10 copies per mil. The second assay is a Roche-Corbas assay, and it amplifies mainly the 3' end of the HBV transcripts. The sensitivity is actually down to 5 copies per mil with a linear range of 10 to 10 to the power 9 copies per mil. So if you look at the performance of these two assays, they're actually pretty similar. A Hong Kong group have tried to look into the HBV RNA level at different stages of hepatitis B and compare that with other HBV biomarkers. So it is started with HBV positive chronic infection. So this is the old immune tolerance group that we are talking about. To HBV positive chronic hepatitis, those are E positive with active disease. And then E0 conversion to E negative chronic infection, that is those patients with inactive E negative disease. E negative chronic hepatitis, those are E negative patients with active disease, to S0 clearance. And they found that for all biomarkers, including HBsAg, HBcrAg, HBV DNA, and HBV RNA, share a very similar pattern that is being higher in E positive and lower in E negative patient, higher in E negative active patient than E negative inactive patient, and lowest among patients who has lost surface antigen. Now, but because of that high correlation and high similarity, we start to doubt what is the additional clinical value of measuring HBV RNA if you already have all other biomarkers in place. So, Mark Guiney and his colleagues in North America tried to get a cohort together of almost 2,000 patients. So these patients are all being followed up longitudinally, and they construct two models. The first model they call base model. They only use patient demographics, that is age, gender, ethnicity, ALT, and DNA to form a prediction model. And the second model, they use all parameters and they perform multivariate analysis and to see which are the independent baseline factor that can predict long-term outcome. And the four outcome of interest. One is non-sustained immune clearance. It means that this patient have got fluctuations of ALT or DNA after ECU conversion. Spontaneous ALT flare, that is unexplained flare, ECU conversion or S loss. And they found that if they use HBV RNA to predict them, on top of this base model, there's actually no additional benefit. If they look at a multivariate analysis also, RNA can only predict spontaneous flare, but not the other three biomarkers. But look at it, the other biomarker that can predict spontaneous flare is HBV DNA. And actually, we all know it. We do not need to do a study on that. So apparently, in untreated patients, we cannot see a clear additional benefit of using HBV RNA to assess disease stages or predict long-term outcome. Now, the use of HBV RNA, in fact, is most attractive in any treated patients because in any treated patients, we do not have HBV DNA. In a treated patient, we have HBV DNA, which is very, very good biomarker to predict almost everything. But after the reverse transcriptase is being suppressed, we do not have DNA, but we still have HBV RNA production. So maybe it is a biomarker that can be used to assess viral replication among any treated patients. So this is another nice study done by a Hong Kong group, 160 any treated patients. So these are all under first-line therapy, ETV, TDF, or TAF. And before treatment, 60% of them had positive E antigen. So 1 year after treatment, look at the blue bar, which is HBV DNA. It goes almost undetectable in most patients, although there are still some patients with detectable DNA, but most of them became undetectable. But HBV RNA, that is a gray bar, although it started at a lower level than HBV DNA at baseline, but after 1 year or 2 years, a lot of patients still had detectable RNA. You look at week 48, still 87.3% had detectable RNA. After 2 years, 77% had detectable RNA. So at least we know that HBV RNA is reflecting residual viral replication even among patients on any treatment. Now, this paper also looked at a quantitative correlate antigen, but they're not testing the ITAC, they're using the traditional one. So you can see a lower percentage of patients had detectable correlated antigen as compared to the RNA. And even RNA is detectable, the meaning of the RNA is still transcription activity of cccDNA. It is not measuring the amount of cccDNA. So this study from China looked at 47 ETV treated patients, and they also had a liver biopsy. So look at the serum HBV RNA, darker the color, higher the correlation. So of course, it correlates best with itself. It correlates pretty good with the liver RNA, have some correlation with the surface and E antigen in the serum, but you see there's no correlation with the liver cccDNA. So again, the meaning is the same. So with remaining RNA on any treated patient, it means that there is still virus replicating. Just the DNA is being blocked, but the virus is still active. Now, active replication definitely would have clinical meaning. So the first study is proposed by Van Bommel's group. So I'm sure a lot of you are aware of this study, 62 NA treated patients. Some patients undergo ECU conversion. Some patients undergo some did not undergo ECU conversion. So among those patients who did not undergo ECU conversion, that is a dark brown bar. If you look at HBV DNA, they also go down. So HBV DNA cannot predict which patient will undergo ECU conversion, which will not, will undergo. But if you look at HBV RNA, clearly for those who did not undergo ECU conversion, they tend to have a high HBV RNA. As compared to those who underwent ECU conversion, the HBV RNA also dropped. So patients with residual replication of virus is more difficult to lose the antigen. So this is the first paper indicating that there might be some clinical meaning behind RNA in NA-treated patients. Now, another important paper actually comes from Nanfang Hospital recently, about 3,000 happy patients on ETV or TDF, followed for a median of 4.4 years. So 90 patients developed HCC. At baseline, 47% detectable DNA and 70% detectable RNA. And it found that for those patients with detectable RNA baseline, they have a much higher risk of ACC. So, but I think this is logical because we all know that replicating virus is associated with increased risk of ACC. I think it will be good to look at for those who had undetectable DNA, and we are very keen to know whether RNA still has a role to predict ACC, and that will be very important biomarker. The same group also look at whether we can predict relapse after stopping NA. So there are 130 E positive patients. They completed clinical trials. In one is terbinafine plus adafovir trial, that is the evaluation group. Another trial is the validation group, and these patients had ETV or TTF taken off. So NA were taken off actually follow the APASO guideline, that is at least after 3 years of ECU conversion and DNA being less than 300 copies per mil for at least a year. So look at the evaluation cohort. Actually, negative DNA and RNA at end of treatment actually perform pretty well. For those patients with double negative DNA RNA, the relapse rate was very, very low, and E reversion rate was 0. However, in a validation set, the data was not so good. You can see a significant percentage of RTO relapse and a significant percentage of clinical relapse. So I think, at least based on this particular study, we cannot conclude that RNA is a useful biomarker to predict who can stop NA, who cannot. And after all, we need to put HBsAg into the equation before we can see and say whether any additional markers are useful. Now, because of that, the Melbourne group also evaluate their study in this NA stop study. So this study was a prospective study among 65 NA-treated patients. So these are E-negative, non-cirrhotic patients being put on at least 2 years of NA, and the DNA must be negative for more than 18 months. Again, they stopped treatment according to the APASO criteria. At the time of stopping NA, 15% had SAG less than 100, 75% had HBV RNA undetectable. And so they're going to look at whether RNA can predict who can stop treatment and who cannot. Now look at the first figure. RNA detectable is in red, RNA not detectable is in blue. So if you just look at viral relapse, most patients have viral relapse. So no matter whether RNA is detectable or not, it did not predict who would develop viral relapse. The biggest difference is here, which is ALT flare, defined as ALT more than 5 times normal and HBV DNA more than 2,000 IU per mil. Then, for those with detectable RNA, they had a much higher risk of hepatitis flare than those had RNA undetectable. Now, if you put HBsAg into the equation, so HBsAg less than 100 and are undetectable is in blue, and then you can see that there's a very low, a lower chance of viral relapse together with biochemical relapse and also hepatitis flare. But RA alone, for those patients with SAG more than 100, could not predict viral relapse, and they could only predict hepatitis flare as in the RA only analysis. So if you really want to predict who had viral relapse, we do need HB surface antigen. Well, now we have many more new treatment. So we know that RNA may have some role in NA-treated patients, but we would also like to know whether this new biomarker is useful in new therapy. I'm not going to talk deep into it, but at least we have entry inhibitor mercury dex. We have CAMs, that is a capsid assembly modulators. There are lots under investigation. We have RNA interference, that is the sRNA, the ASOs or LNAs, and we have some new drugs under development attacking the cccDNA. We have some very early development HBX inhibitors. We have the HB surface antigen relief inhibitor like the NAPs, that is the nucleic acid polymers, and also we have other newer targets. So I want to share with you some concept why RNA may be useful in some of these treatments. Now, this is in an abstract form. It's not published in a full paper form as far as I know. So this is an abstract presented quite some time ago on an arbutus siRNA in E-negative patients. And at that, this part extract, they actually looked into patients who with the biggest drop in different biomarkers and look at the performance of other biomarkers. So I want you to focus on upper panel, which is comparing SAG and RNA. So for this particular patient, he has a biggest drop in HB surface antigen, but HBV RNA is here. So there's actually zero decline of HBV RNA. On the other hand, for this patient who had the biggest drop of RNA in the entire study, the SAG drop was not too big. So in other words, different biomarkers are measuring different things. The lower diagram is actually on core antigen and surface antigen, and exactly the same phenomenon. Biggest SAG drop, core antigen goes up, but core antigen drop, SAG drop only mildly. So in different new therapies, when different biomarkers are measuring things, it indicates the target engagement of this particular new therapy. Of course, some of them for the SAG may reflect some immune clearance. So we need to be very careful to interpret different biomarkers and the meaning behind them when we look into the data of new therapies. Now, RNA may be very useful among patients who are treated by capsid assembly inhibitors. So this is one recent example just presented in AASLD a few months ago. So this is a double-blind randomized cohort in E-positive patient being treated with the legal capsid assembly inhibitor. One arm has an ETV12 with lead, the other arm directly goes to the combination. And you can see that for HBV DNA, among the patient on combination, the drop is deeper than the group already to start with ETV. But after adding on the capsid, the DNA catch up, but the difference was small. You look at RNA, the difference is much, much bigger. The combination arm, again, you can see a serious deep drop in RNA, but the HBV RNA actually declined very, very gently on ETV monotherapy. So after week 12, when the CAM was added, then you can see a very rapid catch-up of RNA decline. So probably the capsid assembly inhibitor under this type of treatment, HBV RNA may be a better biomarker to reflect the target engagement efficacy of the drug than HBV DNA alone. So to sum up my talk, I know it's not too useful, but still there are some conclusive insight I can get. Number one is that pre-genomic HPRNA is reflecting the transcription activity of cccDNA, but not the amount of cccDNA in the liver. Well, at least to myself, there is little additional information in a treated patient from existing biomarkers, and I still cannot see the clear role of HPRNA in untreated patients. But however, in any treatment, I think it indicates incomplete viral suppression. Well, it has some meaning behind it. It might predict high HCC risk. We may need more data to confirm it and see how it can be integrated in the current HCC risk prediction algorithms. The second is it may predict ALT flares after stopping NA, but the role to predict virological relapse is controversial. For new treatment of HBV cure, it indicates target engagement, and it may be especially useful for capsid assembly inhibitors. With that, I want to thank you very much for your attention.
Okay, now you are open to the question from the floor. Do you have any question from the floor? Okay, please identify yourself.
So my name is Dian from Vietnam. It's very interesting. It's actually my resident. I did a small project about this one as well. But in treated patient, like CHP patient, like do you, like how the correlation between HBV RNA and like correlated antigen, because we don't have like a HBV DNA anymore. So do you observe any correlation between them or any?
Well, I haven't come across too much data on that. But I think there will be some correlation because actually correlate antigen also reflects the activity of cccDNA to a certain extent, because the CRAG and the precore protein, they're all produced by the cccDNA. But one important thing is the E antigen part. If you look at the level of correlate antigen, once patient loses E antigen, the CRAG level drop dramatically. But the same phenomenon will not be observed in HBV RNA. So I think, as Dr. Tanaka has illustrated, we have to separate E positive, E negative patient when we work on correlate antigen because of the confounding or confusing impact of EAG in the correlate antigen measurement. But if you E negative patient, I guess they will correlate pretty well. But I don't have solid data to support that.
The second question is similar to the question you asked earlier. So do you have any data in patient like they have HBV reactivation after they have like received immune targeted drugs?
Well, like, actually, you're right. This is something I'm looking forward to see. I don't see any data working on RNA to predict reactivation. I'm not too sure if patient after S loss, if the RNA still can be detected. So this actually, we don't have a lot of data support it. Maybe not, because we are measuring, if you're measuring pre-genomic RNA, after S loss, a lot of cccD activities are halted or become very inactive, like HBV DNA. We may measure some patients with positive HBV DNA after S loss, and I guess it's the same for RNA. But whether it can predict reactivation, I don't know. We definitely need more data to support it, but that's a good suggestion.
And the last point is like, do you have any data in like occult CFP patient?
You mean occult HBV?
Yes.
That those are the patient who had negative surface antigen.
Yes.
But well, I don't have on the top of my mind. At the top of my mind, I don't have any data. But I guess it will be very similar to DNA, that there was a small percentage of patients RNA positive, but the clinical significance is still uncertain.
Great, thank you very much.
Okay, next.
Yeah. Yeah, thank you, Henry. A very, very nice talk. So I just have a comment, and I would like to have your opinion. So you just mentioned that in the untreated patient, the HBV RNA could play a very limited role. At least there's no evidence showing that there is a certain role in predicting long-term outcome. But in my previous research, I focused on correlated antigen, and actually we did find there's some correlation in the long-term outcome. So, but actually, we try to explore whether there is any rule of HBV RNA in the natural history. But the major problem is that most of the serum was stored in the -20. So, but if you want to assay RNA, that could be very difficult because all these RNA could be degraded. So I don't think we have a chance to explore the long-term outcome on the about the HBV RNA in predicting the long-term outcome in patients without antiviral treatment. Yeah. So I think I would like to have your opinion, because you also did some study about natural history.
Well, this is difficult, in particularly for your cohorts of untreated patients. If you still have patients with active disease, that must be more than 20 years ago. So, and if you're an active researcher, those have been 4 and 4 for a couple of times. So that might affect the detection of the RNA. So yeah, it is difficult. If you really want to work on untreated patient going back, it is pretty hard to investigate HBV RNA. Yeah, I think you're right.
So, but I think that correlated antigen, because it's the ELISA assay, it's a protein. So I think we can suggest that this kind of surrogate marker of cccDNA, they do play a role, but we only have evidence from the correlated antigen.
Yeah, but nowadays think about it, with the relaxation of treatment guidelines, I'm sure EASL is going to relax the treatment guideline. So if we are going to liberally treat most HBV patients, biomarkers in untreated patient become less and less important. So the more important would be, say, on the reactivation after S loss, on immunotherapy. So that sort of things, instead of to decide whether you are high risk or low risk. Because if the treatment guidelines are very so liberal. The Chinese guideline is the first one to move extremely liberal. Then all other biomarkers become irrelevant. Even E antigen is irrelevant under the Chinese guideline.
Yeah.
Oh, okay. Please identify yourself.
Professor Chen, very comprehensive presentation. And I have one question that we have known that cancer biomarkers such as the HBV RNA, correlated antigen, surface antigen are related with the HCC occurrence among the CHB patients treated with nucleoside analogs. So do you think any difference among these markers regarding its association with the HCC occurrence?
Well, I think one important thing is if a patient has got persistent virus activity, then HCC risk should be higher. So I think this is a general principle, and all these markers are reflecting this. So in the old days when we have the review study, so HBV DNA is the best marker reflecting viral activity in untreated patients. So we can see a very clear stepwise increase in HCC risk on logarithmic increase of DNA. But now, because a lot of patients are NA, then DNA is gone. Then we need to rely on other biomarkers. So if you ask me to guess, I think RNA and CLAG are better than surface antigen. The reason is because a lot of surface antigen are coming from integrated HBV DNA and they're not reflecting virus activity. So this is my guess. But ultimately, if you really want to remove all HCC risk or make it to a minimum, you need to get rid of surface antigen because the residual the HCC risk may be coming from the cis or trans activation of the human chromosome, but not just the inflammation and virus. So because we are not measuring HBx, and if HBsAg is being produced by the integrated DNA, so why not HBx? So there will be some trans activation activities in the liver going on, and that's the reason why if we look at some data, patients who lose surface antigen have a lower HCC risk than those with on NA but with complete viral suppression with undetectable HBV DNA, and that might be the reason behind. And that's the reason why functional cure still has a meaning, and it's still something that we should go for.
Okay, thank you.
From me. For the decisions, just stopping nuke, we still recommend HBV RNA test or high sensitivity core antigen test.
I think right now I don't have a strong opinion on RNA yet.
Or combinations.
Yeah, well, because right now I don't think we have strong evidence suggesting that adding RNA to surface antigen can improve the prediction who will not relapse after stopping NA. So for me, I won't recommend everyone to do it. Although theoretically speaking, having a negative RNA should be better. But what if I drop the SAG level? Then maybe it's again also better. So we do need some data to guide us whether SAG level alone is good enough. Now we use 1,000 for Europeans, 100 for Asians. But what if I use 10? Then will it be better? Or I should add RNA. So I think we need a bit of data to guide it on this.
Okay. Okay. sorry. And have you done the serum stability assay of the HBV RNA test? Because maybe it is quite stable because it's encapsulated.
Yeah.
Technically.
Yeah, it is. Well, yes, definitely. Yes, you're right. It is encapsulated.
Okay. My last question is that in addition to the capsid assembly inhibitor, do you think this HBV RNA marker will be a targeting engagement for other new therapeutic agents?
Well, certainly for RNA interference, because for RNA interference, again, most of the time we are looking at any treated patients, then DNA is gone. So RNA may reflect some residual virus replication activities, and if we block the RNA production, then that it will also go down.
Okay, we have to close this session. Thank you for all speakers and all attendants. Enjoy this APASA 2024. Thank you very much.
Thank you very much.
Thank you. No. Thank you.